Good afternoon, everyone. Thank you for joining us today. My name is Molly Alawade, and I'm the Director of Education here at the American Kidney Fund. Before I turn the presentation over to today's speaker, I'd like to direct your attention to the control panel, where you should see on your screens. All participants are on mute, so we won't hear you, but we welcome your questions. If you have a question, please type it into the section of your control panel titled Questions. We'll see your questions and we'll do our best to answer them, either by replying to you in the questions box or out loud during the last several minutes of the presentation. The webinar is being recorded and will be made available for viewing on our website, kidneyfund.org/webinars, within the next 1 to 2 weeks. For those of you in attendance who are health professionals, we're glad that you've joined us today and hope that you'll recommend this webinar to patients you work with. However, as a friendly reminder, this webinar is not accredited for continuing education credits. If you believe that your accrediting body may offer you credits for attending this webinar, we'll be happy to send you a certificate of attendance after today's session. Simply email us at education@kidneyfund.org. Without further ado, allow me to introduce today's speaker, Dr. Delphine Tuot. Dr. Tuot is a nephrologist and director at the San Francisco Health Network eConsult program. She is also co-director of the UCSF Center for Innovation in Access and Quality at Zuckerberg San Francisco General Hospital and Trauma Center, or ZSFG, and associate professor of medicine at UCSF's Division of Nephrology at ZSFG. Her current work focuses on the development, implementation, and evaluation of interventions that increase patient engagement in health, translate evidence into practice for patients with kidney disease, and enhance access to specialty care for underserved populations. Thank you, Dr. Tuot, for joining us. Today, our webinar is going to be different from presentations we've done in the past. Over the last few weeks, we've asked you, our audience, to submit questions about kidney disease. We're going to ask Dr. Tuot to answer your questions during the webinar today. We want to thank everyone who submitted such thoughtful questions. Since we only have a limited amount of time during the presentation today, we will not be able to answer all of the questions we received. We have tried to generalize the questions as much as possible in order to benefit the most listeners. At the end of the presentation, you will have another chance to ask questions during the live Q&A. If you have a question, please type it into the section of your control panel titled Questions. Feel free to write in a question at any point during the presentation, and we'll answer them at the end. So Dr. Tuot, I'm going to turn the presentation over to you now to introduce yourself, and after that, we'll dive into the first prepared question.
Excellent, thank you, and thank you for the opportunity to be here. As mentioned, my name is Delphine Tuot. I'm a nephrologist at the Zuckerberg San Francisco General Hospital, and one of my big interests and passions is communicating effectively about kidney disease with individuals at risk and individuals with kidney disease. So it's a real pleasure to be here today.
Wonderful, thank you so much. All right. So our first question, I am newly diagnosed and am quite fearful. What are the most important things I can do to stop the progression of the disease?
So as you know, kidney disease is what I call a bucket diagnosis, so it can be caused by many different things. In the United States, the two most common causes of kidney disease are diabetes and hypertension. And so I think it is important to be able to control the risk factors that have led to kidney disease to help keep your kidneys as healthy as possible and slow down the progression. So if your kidney disease is from diabetes, keeping your diabetes under good control with a good glycemic control and taking medications and exercising and eating a healthy diet are all quite important. If your disease is from hypertension, then the same thing is true. Having a good exercise or having good activity, a solid diet, a healthy diet, a low salt diet, as well as controlling your blood pressure in particular is helpful to stop progression of disease. I also think in general, Alerting and communicating with your providers that you do have kidney disease. Of course, your nephrologist may knows that you have kidney damage or kidney disease, but your other clinicians may not be as in tune to it. And so it's important to let them know and remind them that you have some kidney disease, so that any medications that they may prescribe or any tests that they may recommend, they can make sure that it doesn't harm your kidneys more moving forward. So I think just open communication is also quite important.
Thank you. Those are some great tips. And for anybody who wants additional information, we do have a past webinar on slowing down kidney disease that you could access at any time on our website. All right, so our next question. I was just diagnosed with stage 3 CKD. I follow a very fit, healthy lifestyle. Will CKD prevent me from being highly active?
No, and that's a good thing. CKD, as many of you know, is largely asymptomatic until the very, very late stages or when it is much more severe. In general, stage 3 CKD I consider early to moderate kidney disease, and it really should not affect your lifestyle whatsoever. We encourage, as I mentioned before, activity. I think in general, physical activity is really helpful for the body, not only to help keep your heart healthy and your entire cardiovascular system, but also to keep your kidneys healthy as well. So keep participating in that healthy, active, and fit lifestyle.
Great.
Can I add actually a couple more things to that? Sorry, as I'm just thinking off the top of my head. You know, some people are very, very active, and that is great. Continue that healthy lifestyle, likely the individual who submitted this question. Other people might be a little more sedentary and are a little fearful of starting to become a little more active, and I would say go for it. There are little ways that you can increase activity in your day. That could be parking a little bit further away from the supermarket so that you walk a little bit further. That could mean dancing with your grandkids or with your children or taking a walk with your dog. It could mean taking the stairs at work, maybe two flights, and then taking the elevator the rest of the way. So really trying to introduce activity in any way, shape, or form will really pay off in the end.
Thank you. Those are some great practical tips. So our next question is, my son seems to get frequent UTIs. Is this normal with stage 5 kidney failure?
So just as a reminder, a stage 5 kidney failure is when an estimated GFR, or the percentage of your kidneys, are filtering about 15% or less, so not filtering very much or very well at all. Individuals with stage 5 kidney failure may get urinary tract infections, although it's not necessarily a common occurrence. I think it largely depends, again, on the cause of the kidney failure. If it was an anatomic reason for the kidney failure, that could also predispose to urinary tract infections. If your son or another individual may have a large prostate, so benign prostatic hypertrophy, that can cause UTIs, and in a setting of late-stage kidney disease, you may be predisposed to UTIs. So I would say it's not normal, if you will, but it's not that common. I would chat with your clinician or your son's clinician to make sure that he or she knows that your son is getting frequent UTIs, and to try to see what can be done to prevent further ones. That could include some dietary changes. It could also include some medications to try to prevent ongoing infections.
All right, thank you. So our next question is, what are the initial signs of kidney disease?
That's a great question. I mentioned earlier that kidney disease is largely asymptomatic, meaning that most people will not feel that they have kidney disease at all. On the one hand, that's great because that means that people can live very active, very fulfilling lives without the kidney disease getting in the way. So I think that's a blessing. On the other hand, however, that also means that many individuals may not recognize and may not feel that they have kidney disease, so it doesn't get diagnosed or doesn't get identified very early. That being said, the symptoms of kidney disease, I would say, come from the two different main jobs of the kidney. So the kidney, as many of you know, is responsible for filtering the blood or cleaning the blood. And when it doesn't clean the blood well or filter the blood well, then some toxins or poisons can build up in the blood. And that's usually in the later stages of kidney disease. In the early stages of kidney disease, the disease may be because the kidney is not holding on to protein well enough. And if the kidney is losing protein in the urine, then losing that protein can make the kidney swell, or can make the body swell a little bit. And so some of the early signs of kidney disease may be because of extra fluid and extra water in the body, leading to swelling or what we call edema. Many people will have this in their lower extremities because the water or the fluid uses gravity, essentially, to percolate and settle down. In the mornings, many people may have a little bit of edema around the eyes, what we call periorbital edema, because the water, when they've been horizontal sleeping, the water kind of settles out in that area of the body. So I would say signs of edema or signs of swelling are the earlier signs of kidney disease. The later signs are from toxins building up in the body.
Great, that's a great list of signs. So our next question is, when does a patient's status change from acute kidney disease to chronic?
That's a really good question, and I think not one that is necessarily agreed upon by all nephrologists and all researchers. I think right now, that status changes at about 3 months. So when someone has had acute kidney injury or acute damage for at least 3 months, then it usually gets termed to be chronic. That being said, it's a definition that may not be the same definition in 5 or 10 years. So stick with us so that we can see how we can better define CKD moving forward. I think the important thing to think about is that acute diseases happen sort of over weeks or days and offer more probability of reversibility. So if it's a medication that causes acute kidney disease, we can maybe stop the medication and the kidneys may improve. With chronic kidney disease, it's not impossible, but less common to improve your kidney function. Really, the main goal is to keep your kidney function where it is and prevent it from declining or prevent your kidney disease from progressing.
Okay, good. That's really important to keep in mind. So our next question is, what is the best advice for patients with diabetes and CKD to avoid ending up on dialysis?
I think some of the same recommendations that I provided earlier are valid for individuals with diabetes and kidney disease. I think eating a healthy diet, a diabetic healthy diet, is particularly important. So low in carbohydrates or complex simple sugars, I should say, and eating a low salt diet to try to keep your blood pressure in check as well, because the diabetes and the blood pressure are often synergistic in causing some kidney damage. I think other things are applicable to everybody, not just those with diabetes, and that includes taking medications for blood pressure, for diabetes or glycemic control, for any other chronic conditions. It includes incorporating physical activity into your daily lifestyles. It includes a low-salt diet, as I mentioned earlier, not taking medications that could be harmful for the kidney. And when I say that, I not only mean prescription medications, but also medications that you can get over the counter. So in particular, I think about a class of medications that are called non-steroidal anti-inflammatory medications, things that are ibuprofen and ibuprofen-based. Those types of medications can be really helpful for inflammation and really helpful for fevers and pain, but chronic use of those medications can actually harm the kidney. And so I would be careful in anybody with kidney disease, with or without diabetes, to take those medications chronically. I would avoid it. And if you need a different type of medication, whether it's Tylenol or other ways to treat pain, I would chat with your clinician about that. There are other options that one could try, including acupuncture or even heat or ice sometimes helps for people with joint pains, for example, chiropractor or massages. There's lots of other ways that we can manage pain and not take as many medications.
Thank you. That was really great advice. And for anybody who wants to dive a little bit deeper, we do have 2 previous webinars, one on living with diabetic kidney disease and another one on eating healthy with diabetes and kidney disease, both available on our website. So moving on to the next question, how does caffeine affect the kidneys?
That's a good question. Caffeine, as many of you know, acts as what seems like a diuretic. It encourages the body to urinate. However, there's actually no negative effect that we know of caffeine directly on the kidneys per se, as long as you stay well hydrated with other fluids. So that caffeine itself is not particularly harmful. Just make sure that if you find yourself peeing more and if you find yourself being thirsty, to just listen to your thirst mechanism and make sure that you stay well hydrated.
All righty. So our next question is, what questions should I be asking a nephrologist during my visit?
Yeah, that's a great question. Well, first of all, I want to thank whoever asked this. I think communication with all of your clinicians is really important, and in particular, your nephrologist. I think the things that I tend to talk about or I enjoy chatting about with my patients is, one, just feeling comfortable with the cause of kidney disease. We don't always know the cause, but oftentimes we can narrow it down, and it can be helpful as you're talking about ways to prevent your kidneys from getting worse, as if you know what the cause was in the beginning. So that's one thing I would make sure you talk about. I would also ask about your numbers. Know what your kidney function is at. We look for how well the kidney is filtering the blood, and so we look for a number that's called estimated GFR, or estimated glomerular filtration rate. That's a mouthful, but if you can just ask what your kidney numbers are and how it's filtering, I think it's really helpful to know where it is, and if you've been able to stabilize your kidney function through healthy habits and healthy activities. I would also ask your nephrologist about the amount of protein you have in the urine. That's the other test that we check to see how the kidneys are doing and whether kidney disease is remaining stable or it is progressing. So again, I would follow those numbers and keep track of them, either at home or on a patient portal if you're able to see your laboratory tests from your nephrologist's office. So those are the laboratory tests that I would ask about. And I would also ask what she or he thinks you could be doing to improve your kidney function. He or she may have a specific recommendation that is pertinent just to you, and if you don't ask, maybe it won't come up. And then lastly, I would just make sure that anything you take over the counter, any supplements, any other over-the-counter medications, cold medications, cough medications, I would just make sure you bring them, if you're using them frequently, to your visit so that you can ask your nephrologist whether they're safe for your level of kidney disease or kidney function. Those are the main questions I would ask. In individuals with later stages of chronic kidney disease, kind of nearing kidney failure or nearing the time when maybe a transplant or dialysis may be helpful, I would start asking your nephrologist about which options might be best for you. And I would chat about your preferences and what your goals are. If your goals are to stay at home as much as possible and not go to a dialysis center, then maybe a home dialysis therapy might be best for you. And maybe you have individuals who could and are healthy enough and can donate a kidney to you. And asking your nephrologist whether that would be a good idea and whether that's safe for you is really important. And so sometimes nudging your clinicians to have these discussions is really helpful if they forget to do so.
Wow, that's a really useful list of questions. If anybody wants to do a deeper dive, we do have a webinar on tips for talking with your doctor available online. So our next question is, what does a high level of protein in my urine mean, and what can I do about it?
So as I mentioned earlier, there are two main tests that we do to test for kidney disease. The first is how well the kidney is filtering the blood, and that's what we call the eGFR. eGFR, it's not perfect, but I think about it often as a percentage, like how well your kidneys are filtering your blood. If 100% means that, if 100 means that they're working 100%, then maybe 50 or 60 means that they're only filtering about 50 or 60%. It's not perfect, but that's a rough correlation. The other test that we look for is protein in the urine. So the other job of the kidney, in addition to filtering the blood, is to hold on to protein. And I sometimes think about this like a coffee filter. If you think of your kidneys that are filters like a coffee filter, it holds on to the coffee grains, so holds on to your proteins while allowing urine or fluid or coffee or whatever to pass through. And those are the waste products. I mean, coffee is not a waste product, but you can get what I mean. The fluid kind of comes through. And so when there are coffee grains that go through the filter, or in our case, protein that's going through the kidney and ending up in the liquid, and then that's abnormal. And so having protein in your urine means that your kidneys are damaged and that they're not holding onto the protein the way they should. And that is one of the early signs of kidney disease. There are a couple things that can be done about it. It, of course, depends on what the cause of the kidney disease is or what causes the protein from leaking into the urine. If it's an autoimmune cause or a genetic cause, then maybe certain medications or certain therapies might work. More generally, we have some medications that we use that help the kidney hold on to that protein. These medications are called ACE inhibitors or ARBs, angiotensin receptor blockers. Those medications in particular help the kidney hold on to protein. In general, also maintaining a good control of your blood pressure can also help the kidney hold on to protein. If you think about it, if you have really high pressure, there's a lot of pressure going into that kidney, and it's much easier for the kidney to lose protein through its filter when the blood pressure is really high. So controlling your blood pressure is really helpful for that as well.
Okay. So our next question is, what are ways to lower blood pressure caused by kidney disease other than medications?
Of course, so medications are clearly very important, but there are other ways that can help lower blood pressure. I find physical activity can help lower blood pressure. While you're doing your physical activity, your pressure may go up, and that's to be expected. But chronically, after you've incorporated physical activity into your daily routine and your weekly routines, your body actually settles out and your blood pressure decreases a little bit. Some weight loss, as appropriate, can also help lower your blood pressure. And Mindfulness, I find, and stress reduction activities are very helpful to lower blood pressure as well. I must say I don't do a great job at this myself, but many of my colleagues and many of my patients have found ways to incorporate yoga or incorporate meditation into their routine, and those types of activities can just help reduce blood pressure and help reduce the stress level.
So, sticking with these questions about medication, here's our next question. Are there medicines to treat kidney disease?
So there are medications that help reduce the protein in the urine, and so those are to help treat kidney disease. Right now, we do not really have medications that are commonly used that help reverse kidney function, although there are many that are being tested and that are being examined thoroughly in laboratories and in the research environment. If your kidney disease is from a generalized or what we call systemic disease, so something like lupus or something like scleroderma or another type of disease in general, if we treat those general diseases, we often can treat the kidney disease that's associated. So it's not quite an answer to this question, but it's close. Know that there is a lot of research going on in this space to see how we can develop and find medicines that are specifically targeted at reversing some of the kidney disease and kidney dysfunction.
Great. All right, so Dr. Tuot, you've mentioned eGFR a couple of times this afternoon, so the next couple of questions are going to focus on that. So our next question is it possible to improve my eGFR level?
So yes and no. eGFR, it's important to know it fluctuates a little bit every day. So I want to make sure that people understand it's not a perfect test and it's not a static test. So on a day, for example, when I may be a little dehydrated, my eGFR may be a little worse than on a day that I'm hydrating well, but it's within a similar level, within like 3 to 5 milliliters per minute. And so that I consider fairly stable, but it does fluctuate a lot. Now, when someone has acute kidney injury, as was, I think, asked earlier during this webinar, that's usually an acute or a very sudden process that causes a decline in eGFR. And oftentimes, because it's an acute process, that eGFR decline is reversible. It's either we just need to find the medication that's causing the problem, or the dye that has caused the problem, or treat the infection, or whatever disease is causing the acute decline in eGFR. In terms of a chronic kidney disease, is it possible to improve the eGFR level? It is much harder to improve your eGFR if you've had a low GFR for years. I would say not impossible, but very challenging to do. And most of what we focus on is trying to slow the progression. I think the reason for this is because if you think of the kidneys as 1 million filters in each kidney, you have chronic kidney disease when those filters aren't working. So when they've died or when they have scarred because of a previous insult or injury. And so the kidney cannot regenerate those filters, which is why it's really hard for your eGFR level to improve. Again, not impossible in certain circumstances or situations, so it's really important to ask your nephrologist or ask your primary care doctor about that, because everybody is a little bit different, and it's important to recognize those differences and those nuances.
Okay, so here's our next question about eGFR. What is a normal creatinine level, what is a normal creatinine and eGFR level for someone over 80 years old?
I think the answer to that is no one knows. Creatinine is based off of muscle mass, as many of you know. So individuals who are bodybuilders with really big muscle mass will have a higher creatinine, and that may be normal for them, actually. For somebody over 80 years old, they tend to have less muscle mass because they're not bodybuilding as much, if you will. With age, our muscles tend to shrink a little bit, and so we have less muscle mass, and so creatinine will be lower in individuals with less muscle mass. But it's really hard to give a specific creatinine for an age cutoff because everybody is different, and one 80-year-old may be more active than another 80-year-old, and that activity will then impact your muscles and your muscle mass, and therefore your creatinine. So I would say I can't really give an answer for that, but I hope I have conveyed how creatinine can be different for different individuals. Now, eGFR is just an equation that we use to measure how the kidney is filtering, and it's based off of creatinine. So if someone has a low creatinine, they'll have a higher eGFR. And so again, I can't really say what would be normal necessarily for someone over 80 years old. We do know that it is considered normal for your kidneys to age, just like the rest of the body ages. And so it is perfectly acceptable for someone's eGFR to slowly decline with age. How much is normal, I think, is still up for debate and depends on depends on the individual.
That's a great explanation. Thank you. So our next question is, what's the difference between a nuclear GFR and estimated GFR? And why would there be large difference in my results?
So, as I just mentioned before, we calculate an estimated GFR based on a couple different variables, including the creatinine level, but also with age and with race ethnicity introduced into the equation. And an estimated GFR is exactly that. It's an estimate of how the kidney is filtering the blood in the body. And if your creatinine is higher or lower than maybe an average, your GFR may be higher or lower than it should be. The estimated GFR will be higher or lower. So it's not a perfect calculation, but it is one of the steadier ones and one of the best ones that we can do right now in regular clinical practice. A nuclear GFR is often after a nuclear test has been done, and so that's where some dye or a medication may be introduced to a person who then undergoes imaging, and you see where that dye or that medication then flows. And that's perhaps a more accurate measure of how the kidney is filtering, because it is being measured, it is more accurate than an estimate, which is an estimated GFR. So I hope that is the difference. One is more of an actual measurement, and the other is an estimate. Now, nuclear GFRs or even measured GFRs in other ways, in other tests, is actually really time-consuming and hard to do, and is not something that we necessarily recommend regularly. Because in general, the estimated GFR is sufficient and is a good enough proxy for how someone's kidneys are filtering. If in your circumstance, your provider thought that your estimated GFR was perhaps too high or too low and wanted a nuclear GFR just to be certain, that's probably the scenario in which you would have a difference between the two. And if there is a large difference, usually the nuclear GFR is the more accurate one, and then you can try to incorporate that into your estimates moving forward, because a nuclear GFR is really hard to continue to obtain on a regular schedule.
Okay, thank you for that. All right, so we're gonna talk a little bit more about CKD and ESRD. So our next question is, what is the average time to progress from diabetes to CKD to ESRD? And how long would it take to go from CKD1 to CKD5?
So that's a good question. It's important to note that this question is about averages. Again, everybody is different and everybody's physiology and body is different. And it depends on really how well your diabetes is controlled and the type of diabetes someone might have. So for the most common type of diabetes, particularly in the United States, it's diabetes type 2. On average, people with diagnosed diabetes will then start to have albumin in the urine or protein in the urine around 5 to 7 years after being diagnosed. And that is an earlier sign of kidney damage because the kidney is losing protein into the urine. And then after that, around 10 to 15 years, and I recognize it's a very long, wide range, but on average, after that, 10 to 15 years after being diagnosed is when we may start to see filtering problems. So your eGFR may be low, causing or leading to chronic kidney disease. Now, from stage 1 CKD, which is when you have abnormal amounts of protein in the urine but normal filtration, down to stage 5 CKD, which is abnormal filtration, so your kidney is not filtering the blood well, can be many, many years. And there are many individuals with diabetes who develop stage 2, stage 3 CKD and never progress and stay at stage 3 CKD or stage 2 CKD. And so it's important to note that you can slow down the progression through good diabetic control and good healthy lifestyles, as we've been talking about for the last half hour or so.
Thank you. All right, so our next question is, does an ESRD patient's non-compliance with dialysis treatment and diet cause more damage to their long-term kidney function and lifespan?
So individuals with end-stage renal disease, meaning that their kidneys are no longer working sufficiently on their own and they need dialysis or need a transplant to perform the activities that the kidneys would normally do. If you think about the kidneys, they normally work 24 hours a day, 7 days a week. And dialysis right now is intermittent. So the most common form of dialysis is 3 times a week, or some people can do dialysis at home, which may be more frequent, 5 or 6 days a week, some people 7 days. So non-compliance with dialysis means that their body is not getting the filtering, is not getting cleaned the way it needs to be cleaned because the kidneys are no longer working and dialysis is the only way to filter or clean the blood. So not going to your dialysis treatments means that you're not getting that filtering, which does cause harm. That means that the more poisons or toxins have built up in the body and your blood is not getting cleaned. That can be harmful for your heart. That can be harmful for the brain, actually, and it can be harmful for your overall lifespan. It probably does not cause more damage to your kidneys because your kidneys are already not working, and that's why you require dialysis. But it does affect the rest of your body. So it's really, really important to figure out a way to make your dialysis treatments. And it's important to talk with your nephrologist and your other team members, social worker, nurses, dialysis techs, pharmacists, your peers, to troubleshoot why you're having a hard time going to your dialysis treatments. If it's a transportation issue, maybe try to figure out if there's a different method to get to dialysis. If it's the time of the day, maybe try to see if maybe there's an opportunity to change the time. There could be many different reasons, and again, this is very individualized, but it's really important to chat with your team to overcome some of those barriers because it's really important to go. I think similarly with diet, the diet that we recommend for end-stage renal disease is really challenging. Everybody acknowledges that. It is really hard. We ask for a low salt diet, we ask for a low phosphorus diet, we ask for a low potassium diet. A lot of people don't find those diets very appealing or appetizing, and I totally get it. And so working with a dietitian at your dialysis center to try to figure out what are some of the foods that might be more appealing to you that could still be within your prescribed diet. It is hard, I know, but it's really important. In particular, because high potassium can cause heart problems, and high phosphorus can lead to heart disease down the road, as well as bone disease, but I worry more about the heart implications, actually. So trying to figure out ways to adhere, crafting a good diet or a diet that is best for you is really important. And I think individualizing that diet is important as well. So making a diet, what do we call them, a food diary, maybe 1 or 2 days out of the week, just jotting down everything you ate. And that can be really helpful to try to figure out which are the foods that might be less good for you and what you could substitute them for.
All right, so our next question, and I think this is the last prepared question that we'll do, and then we'll jump to the live Q&A. So the next question is, I'm on dialysis. Why is my skin so dry and itchy, and what can I do about it?
Yeah, that's a common problem, and I wish I had a magical solution. In general, the itchy skin from individuals with end-stage kidney disease is because there have been some toxins that have built up in the body and in the skin that are not maybe removed as effectively with dialysis or with our treatments. So that is probably why your skin is dry and itchy. And what I recommend is what a lot of my colleagues I have found recommended in chatting with dermatologists is just really thick lotions. Some people even use Vaseline because it's really thick and it helps keep bone moisture into your skin, and those can be really helpful. I recommend using lotion twice a day to my patients who are on dialysis or who require dialysis so that their skin is not as itchy. I think other contributors to itch include high levels of phosphorus. So if you're able to maintain your phosphorus in a good level with either medications or dietary changes, I think that could be helpful. It doesn't solve the problem. Even individuals with really good phosphorus may have itchy skin because of the toxins. But having a good level of phosphorus is helpful. And then I also find that there are some medications that can help reduce the itch level. Some medications such as gabapentin is one. There are others in that class that can be helpful. It rarely removes the itch altogether, but the gabapentin or similar medications can help your body react to the itch or react to the toxin slightly differently so that you're not as itchy. So talk to your clinician and talk to your nephrologists about it if you do find yourself being really itchy.
Thank you for that advice. So we've received several diet-related questions this afternoon and in some of the submitted questions. But since Dr. Tuot is not a dietitian, we won't be asking her any of those specific questions today. We encourage you to talk with your primary care doctor or a dietitian about any specific diet questions you may have. And in the meantime, AKF has hosted several webinars on many diet-related topics that you see here on the slides, and many of those webinars may have the answers that you need. And here are some more diet webinars, and all of these recordings can be found on the AKF website, kidneyfund.org. And as a reminder, the slides from today's presentation will be posted to the AKF website within the week. All right, so now we're going to transition to the live Q&A. So thank you to everyone who submitted questions. All right, let's jump in. So how is it possible to go from no kidney disease to stage 3? What happened to stages 1 and 2? This is coming from someone who has regular blood work.
Yeah, that's a great question. So stage 1 and 2 kidney disease is defined by abnormal protein levels in the blood with fairly normal filtration. So your eGFR is above 60. 60 is sort of the cutoff that we use to define chronic kidney disease. So if your GFR is, say, 70 or 80, we consider it in the normal range, if you will. But if you have protein in the urine, then you would have stage 1 or stage 2. Now, if you've never had protein checked before, then maybe all of a sudden, over time, your eGFR goes down a little bit and goes under that threshold of 60, and now all of a sudden you have chronic kidney disease stage 3. So that could be one option. I think another option is sometimes there are these acute changes, so acute kidney injury could happen. So if someone has been hospitalized for a bad infection or a bad disease or had a bad reaction to certain medications, you can have an acute kidney injury. So all of a sudden your filtration will go down, and usually those get better. But there's some circumstances where the damage was so profound that it doesn't actually improve, and you end up with some chronic kidney disease fairly suddenly, which is not very common, but can certainly happen. I think regardless, it can be a shock. There's no doubt about it. The first couple times you hear about kidney disease. And I think it's really important to recognize that that does not mean you can't have a normal life, and it does not mean that you can't participate in all the activities you wanted to beforehand. And it can be a nudge to try to be even healthier in your habits and your diet to try to keep the kidneys as healthy as possible.
Great. So here's our next question. How can I explain my CKD in a way that a regular person would understand?
Yeah, I wish I had the $1 million answer to that. I'm always seeking for better ways to explain it as well. In general, as I have done during this webinar, I explained kidney disease basically through the two big actions of the kidney. The kidney filters blood and the kidney holds onto protein. And those are the two big roles of the kidney. The kidney, of course, does many other things. It helps make your red blood cells. It helps your bones stay healthy. It helps your blood pressure, control your blood pressure in the body. So it does many other things. But really the two main ones are filtering the blood, cleaning the blood, and keeping the protein into your body and not allowing it leak into the urine. And so those are the two things I talk about when I describe kidney disease. And someone can have kidney disease if they have an abnormality in either the filtering mechanism or they're leaking protein into the urine. So I use that coffee filter analogy, that the filter has holes in it and protein is leaking into the urine, the way coffee grounds would leak into your coffee. And so an abnormality with either one of those is what leads to a diagnosis of kidney disease.
Great. So we have a question from a transplant recipient. So if I've had a kidney transplant, does that still mean I have kidney disease?
That's a good question. So I would say yes and no, which is maybe not a satisfying answer. I think in general, we just for our research purposes and to make sure that we monitor your kidney function really well, we still classify anybody that has had a kidney transplant as having kidney disease. But it's odd because you could have a very normal filtration and you could have had zero protein in your urine. And so your kidney, your transplanted kidney is actually working really, really well. So I would talk to your transplant nephrologist or your regular nephrologist in asking what your GFR is and what your level of proteinuria is. Because if both of those are okay, even if we classify you as having kidney disease, your kidney is actually doing just fine, meaning that you're taking really great care of it.
Great. Okay, we have another question about kidney donation. So someone is considering becoming a living donor. Is there an age limit? What lifestyle changes would you recommend to be in the best shape?
That's a great question, and props to whoever is thinking about being a kidney donor. I know it can be really scary, but I hear it is one of the most rewarding activities or rewarding moments in people's lives. Being a kidney donor, we will only allow you to be a kidney donor if we feel like it is safe for you and not harmful for you in any way. And so that means that we need to make sure that you don't have a risk of high blood pressure, or you don't have high blood pressure, that you don't have diabetes, and that you have a good weight level. So in general, I recommend individuals who are thinking about donating to make sure that they stay active, because while the transplant surgery is not a big one, and the transplant surgeons have made such progress in the last 40 or 50 years, it's still a surgery. And so the most physically fit you are ahead of time, the quicker you'll rebound post-surgery. So I tell people to try to be active, make sure their blood pressure is well controlled, and make sure that they have a good weight level. Oftentimes, transplant surgeons may not recommend that someone be a living donor if they are obese or have too much weight. And the reason for that is often because of the potential surgical complications, and it's harder to bounce back after the surgery. So those are the things that I would focus on. And I don't think there is actually an age limit, although I think that that probably differs from transplant center to transplant center. And I suspect there are many factors involved in whether someone is allowed to donate at an older age or even at a younger age. And a lot of that includes your risk for kidney disease or your risk for high blood pressure after donation.
Great, thank you. So our next question is, what does a kidney biopsy reveal to doctors or patients?
So as I mentioned maybe at the very beginning of the webinar, kidney disease is just defined by the kidney not working as well as it should. It doesn't really tell us why the kidney is not working well, what the causes of the kidney disease. Now, oftentimes, based on history and based on physical exam and some laboratory tests and looking at the urine, your nephrologist may be able to deduce and say, you know, I'm 95% sure that your kidney disease is from X, whether that's diabetes or hypertension or a medication. But sometimes the situation is not that clear cut. And so a kidney biopsy is really helpful in those scenarios. What a kidney biopsy does is we put a small needle into the kidney and take out little pieces of tissue about 1 centimeter long, and we hand that over to our pathologist, to our colleagues. The pathologists make tiny little slices, and we all look at it under the microscope. So we can see on the microscope level where the damage is, so what part of the kidney is damaged, whether there are extra proteins there, whether there's an immune response, whether there's an infection there. So you can really see and get a much better idea of what the cause is of the kidney disease, which is really, really helpful. I think additionally, we get a good sense of how long the kidney disease has been happening. It's not perfect, but we have a sense of whether there's been just a little bit of damage or whether it's more of a chronic process. And for individuals who are new to the system or may not have had doctor's appointments kind of throughout their lifetime, and this is the first time they present and the first time they've been told that they have kidney disease, that being able to see and to estimate how long the kidney disease has been occurring can be really helpful when you talk about medications or treatment strategies with your patient and with your doctor. So I think those are the two main things. It helps us better identify what the cause is, and it helps us identify chronicity, or how long we think the damage has been ongoing. I will say, however, a kidney biopsy is also not perfect, because as I said, there are a million filters in the kidney, and with each kidney biopsy, we're lucky if we get about 20 glomeruli or 20 filters, some more, some less, but we're really looking at a snapshot in one little area of the kidney, and we're assuming that it's representative of the rest of the kidney. Usually that assumption holds up, but in some circumstances it doesn't, which is why sometimes a biopsy may not yield the answers that we or our patients are looking for.
Thank you. All right, so here's our last question this afternoon. Is cranberry juice good for the kidneys?
That's a great question. I don't think cranberry juice is either good or bad for the kidney. Cranberry juice has been found to decrease or has been associated with fewer urinary tract infections, but I don't think it's from an action that is specifically kidney related. I think it's an action in a different part of the GU tract. I will say you do want to be careful with drinking any types of juices, particularly individuals with diabetes, as all of those juices do contain a fair amount of sugar. So that would be the only thing I would just be cognizant of or aware of, is the amount of sugar in the cranberry juice that you may or may not be drinking.
Great. Well, thank you so much, Dr. Tuot, for joining us and providing such thoughtful answers to our webinar questions. So this concludes today's webinar. Our next webinar will be about anemia and kidney disease. The webinar will be held on Tuesday, February 19th, and hosted by nephrologist and anemia expert, Dr. Jay Wish. Registration is open now. Visit kidneyfund.org/webinars for more information and to register. When the webinar closes, please do not close your browser window. You may see a pop-up saying that the webinar has ended. Please close that pop-up and proceed to the webinar evaluation survey. Your honest feedback will help us make our webinar program the best it can be. Thank you for joining, and we hope to see you again.